Hello and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of October 7th. Respiratory virus season is right around the corner, and most of our questions are related to that, so let's get to it. First question, is Synagis no longer recommended for RSV? Are there any remaining indications for Synagis? So this is a great question. So we know that RSV is a major problem. We know that millions of patients every year get infected with RSV, and it leads to about up to 80,000 hospitalizations every year and up to 300 deaths in children. We also see that there are higher rates of infection and mortality in adults, but that's a different discussion for a different day. So with RSV, the highest risk that we see is in young infants, and especially preterm infants. But there's other groups that tend to have problems in that age range as well. And so we're looking at children who have chronic pulmonary disease, neurologic conditions, cardiac conditions, and immune compromising conditions. And so these are all children that tend to have higher rates of morbidity and mortality. We also see more problems with RSV in children who are of Alaskan Native and American Indian heritage. RSV tends to be a seasonal virus, usually shows up sometime between October and March, but there are some places that have different seasons depending on where you are. So for example, Florida and other tropical areas tend to have a longer RSV season, and other places like Alaska may have a different season as well. So it really depends on where you are as far as when the risk of RSV tends to show up. Around our area, we tend to see RSV peaking around January or February. We also saw that after COVID, RSV started having a different season to a certain degree as well, and so things may change depending on how the year goes. With Synagis, or palivizumab as it's also noted, it's a monoclonal antibody that has been used to try to prevent hospitalization in certain high-risk children. It was licensed initially in 1998, and as times changed and more evidence and experience occurred, then they changed the recommendations for who should receive it. And so at this point in time, it's a monthly injection that's given throughout the RSV season, and we found that in the high-risk patients, it's about 50% effective at preventing hospitalization. It's important to note that RSV protection doesn't extend preventing infection or other morbidity or mortality when it comes to Synagis. When we look at who Synagis is indicated for, I'm sure you're pretty well aware, but it depends on the first versus the second season and what your risk factors are. The current indications are if you're less than 29 weeks gestation at time of birth and you're less than 12 months old at the onset of the RSV season, then you would have the indication for receiving Synagis for trying to prevent hospitalization. If you are less than 32 weeks gestation and have chronic lung disease or hemodynamically significant congenital heart disease, then you could also receive Synagis during that first season. And there's consideration for severe disease when it comes to cystic fibrosis and other patients with neuromuscular or other pulmonary conditions. In the second season, those same high-risk patients may have indication for Synagis depending on the situation. So that's palivizumab or Synagis. Along comes nirsevimab or Beyfortus this last season when it was approved and started to be rolled out in use. And this is also a monoclonal antibody, but the difference is that it only requires a single dose and it's less expensive than Synagis. The other nice thing is that instead of just covering about 5% of the pediatric population like Synagis does, this has the potential for protecting most children ages 8 months or younger at the onset of RSV season. And so the clinical trials and the real-world data of use that we have so far suggest that Beyfortus can decrease hospitalization up to 80% in children 8 months and younger at the time of entering RSV season, and is close to that for preventing any healthcare visit. So this is very different than Synagis that only prevented 50% hospitalization rate. This Beyfortus has the potential to prevent any healthcare visit. So it looks like it's going to be much more effective than Synagis is. There also may be a benefit in the second RSV season for the high-risk patients again. And so these are 8 to 19 months of age at the time of entering that second RSV season, and these are the patients that have preterm birth with chronic lung disease or immunocompromised state or severe cystic fibrosis or children who are of American Indian or Alaska Native heritage. The other option that's out there now too is to vaccinate the birthing parent during gestational age 32 weeks to right under 37 weeks as they're entering the RSV season. And so the efficacy of that is actually similar to Beyfortus as well. So we have a couple of options in addition to Synagis now. So because the Synagis is not as effective, Beyfortus is really the preferred agent at this point in time. And you'll notice that the recommendations really focus on that. And so Synagis is still available for those high-risk patients if Beyfortus is not available or if the mother did not get vaccinated. So you'll notice that there's really not much discussion about Synagis anymore, and again for good reason. If Beyfortus is unavailable, then Synagis can be administered, but ideally if Beyfortus becomes available, you could switch to the single dose of Beyfortus and finish out the coverage for the rest of the RSV season. AAP Red Book has a really nice algorithm in it that really goes through all the ins and outs of who should receive Beyfortus or vaccination during that first RSV season and who it's indicated for in the second, and where Synagis may fall in those patients if it's indicated. So question 2, for a child under 4 years who had 2 doses of the 23-24 COVID vaccine, how many doses are needed for the 24-25 version? So short answer here is it depends on the vaccine and the number of doses that have already been administered. But let's talk a little bit more about the COVID vaccines and the iteration. If you remember in 2020, Moderna and Pfizer produced the mRNA vaccines that then became available to patients, including children eventually. In 2022, they updated that to a bivalent option that had the original strain and then included the Omicron variants BA4 and BA5. And then 2023, they switched to a monovalent option that had Omicron XBB strain. So now we're in 2024, 2025. Once again, it's monovalent vaccine, and the mRNA used the Omicron KP2 strain, and there is a subunit vaccine, Novavax, that uses the JN1 strain. COVID vaccination is recommended for all patients 6 months and older unless otherwise contraindicated. The mRNA vaccine is available for 6 months and older, and the Novavax subunit vaccine is available for 12 years and older. There's no preference of one vaccine versus the other, but if you mix and match, it makes it a little more difficult for trying to sort out if somebody is up to date or not. If you're looking to see what the most up-to-date recommendations are for vaccination, the CDC is your best bet. Even then, sometimes things move quickly and not everything gets updated in a timely fashion. So for example, if you look at the CDC recommended immunization schedule for children, it still lists the 2023-2024 option, but you can basically substitute the 2024-2025 option. If you search 2024 to 2025 COVID-19 vaccine immunization schedule for people 6 months of age and older, it will pull up a CDC-based PDF that has a really nice infographic about who needs what doses of the 2024-2025 formulation. The most complicated group there is the 6 month to 4 years old, so I'm assuming that's why the question was asked, because it is somewhat complicated. Basically, those are the ones that need the multi-dose initial series, and it depends on which series you got. So for example, Moderna has a 2-dose series 4 to 8 weeks apart for that initial series. Pfizer has a 3-dose series 3 to 8 weeks apart between the doses for that initial series. That's your initial series backbone. If you've gotten all of those and it's with the current formulation, which obviously wouldn't have happened yet because we just got that, but if you're in that situation, then you're good to go for this season. If you have not gotten that full series, then basically you fill in the blanks with the new formulation. For example, if you had the Pfizer series and you got 2 doses with a prior year's formulation, you need a 3rd dose to finish your series. You just fill in that blank with the new 2024 to 2025 formulation. If you're missing 2 doses, then you give 2 doses of the 2024-2025 formulation. If you've gotten all of the series in a prior year in that age group, you just need a single dose to be up to date with the new 2024 to 2025 formulation. The other ages, the 5 to 11 and the greater than 12 years old, if you're using the mRNA, it's a single dose for the initial series. It's a single dose for the updated vaccine. If you've gotten a prior year but haven't gotten the current formulation, then it's time to get a new dose with the new formulation. If you're using the subunit vaccine vaccine, the Novavax for 12 and older. It's a 2-dose series for the initial series. It's a single dose for updating. Okay, question 3. For patients 2 years old and up, would you recommend the new FDA-approved nasal vaccine FluMist, available in 2025 for self or caregiver administration, over the standard influenza vaccine? Another great question. Lots of vaccines out there when it comes to influenza. Influenza is another virus that causes major problems. About 50,000 people die in the U.S. every year from influenza. Some years are better than that, some years are worse. We know that there are almost 200 pediatric deaths from influenza this last year, and it's been one of the highest seasons ever for that. Unfortunately, about 80% of the children that died from influenza could have received a vaccine and didn't. And close to half of the children that died from influenza had no underlying medical conditions that would suggest that they're at higher risk for influenza. The other problem is that not only does it kill patients, but it also leads to healthcare visits and hospitalizations and all the problems that go along with it. The other problem too is that our antivirals for influenza just aren't that effective once influenza establishes itself. So really the key for influenza is prevention. And we've got several vaccines that are available that, while not perfect, do a pretty decent job. We're spoiled with some of these other vaccines in that they're 100% effective in preventing disease or close to it. Unfortunately, influenza vaccine isn't like that. And because influenza changes all the time, we're often playing catch up. Even though these vaccines aren't perfect, they're still estimated to prevent 10,000 deaths every year in the U.S. and prevent millions of healthcare visits every year. So there's a real benefit there. The other thing is that even if you get breakthrough infection, if you've been vaccinated, you actually have a better chance of having lower morbidity compared to someone who got infection and wasn't vaccinated. So again, a real benefit to these vaccines that aren't perfect. We look at what vaccines are out there. There are live inactivated options, there's inactivated options, there are egg-based and other cell culture options. Lots of different possibilities out there. One of the interesting things is that since COVID, with social distancing, the Yamagata B strain is no longer circulating throughout the world, and so our new formulation is only a trivalent formulation because we no longer need to cover for that strain. The egg-based inactivated options are things like Fluzone, Flurix, Flulival, and Afluria. There are other inactivated non-egg-based options like Flucelvax and Flublock. Then we have FluMist, which is the live attenuated intranasal administered vaccine that is out there. It can cause bronchospasm and it can cause things like runny nose and sore throat, and because of that bronchospasm possibility, it's not recommended for children that are 2 to 4 who have asthma or children who've had a wheezing episode within the last 12 months. It's otherwise indicated for healthy people 2 to 49 years old. Because you're administering it into the nose, then it has a chance to spread for people who have a CSF leak, so it's not recommended for people who have CSF leak or cochlear implants who can develop CSF leak. And then it's a live virus, even though it's attenuated, so it's not recommended for pregnant people or people who are immune compromised or people who have close contact with people who are severely immune compromised. Also, because it's live virus, it's not recommended if you have received an antiviral within the last 5 to 17 days, depending on which antiviral, because it may impact the ability of the vaccine to produce immunity. When it comes to the influenza vaccines, there's not any one vaccine that is preferred over others. As the question indicated, last month the FDA approved home administration of FluMist, so the intranasally administered vaccine, and this was based in part off of a few studies that are out there. One of those studies looked at 4,500 adults, and they looked at a cohort that self-administered the vaccine at home, and the other was administered by a healthcare provider. And what they did was they looked at the rate of febrile illness throughout the season after that in each cohort, and they also looked at side effects from the vaccine itself to determine, was there a reactogenicity from the vaccine? So things like sore throat and runny nose and that sort of thing that we know happen often after the vaccine. And they found that the rate of reactogenicity was similar in both groups, indicating that both administered the vaccine effectively. And they also noted that the rate of febrile illnesses throughout the season was similar, suggesting that the vaccine worked to the same degree, whether or not you got it from a healthcare provider or at home by yourself. There was another study that looked at 1,000 adults that had a similar situation of home versus healthcare administration, but this time they measured antibody response, and they found that the antibody response was similar in both, again suggesting that home administration is effective and safe. And not surprisingly, most of the participants in the study actually preferred the home administration. There was a small feasibility study in children looking at whether or not parents could administer it, and it seemed to go well, but again, these were small numbers in kids. Looking at this, it suggests that home administration is a viable option, and we'll just kind of have to see how things play out. Remember that FDA approval is just one step in the process of recommending use of a vaccine or other medications, and we'll see if the AAP, the CDC, and ACIP have any particular recommendations in the coming months. But from my standpoint, the more I see, the more I think that this is a viable option. And when you consider that we already are not great in preventing influenza and getting vaccines into our patients, having another option that makes it more convenient is a really attractive one. I, for one, think that this is probably a good idea, but let's see what the experts say, looking at everything and all the ins and outs. However it gets done, it needs to be done in a logical and effective fashion, and we'll need to make sure that people are appropriately chosen for who should be getting this vaccine at home, and ideally making sure that we're able to adequately and appropriately document that these vaccines are being given, both from a standpoint of surveillance, but also from a standpoint of seeing if any adverse effects occur. Right now, it's unclear exactly how it would be administered. In the FDA announcement, they mentioned that the vaccine manufacturer is planning on using a third-party pharmacy to screen and distribute these vaccines. More to come on this, and hopefully this will be another tool that we have in our armamentarium in preventing influenza in our patients. All right, so question number 4. With the growing concern of antimicrobial resistant bacteria in children, what advice can we give parents to decrease the risk of their children becoming antibiotic resistant? So yet another great question. We know that antimicrobial resistance is a major problem. So the CDC estimates that about 1.7 million people die every year worldwide because of antimicrobial resistant infections, and they estimate that about 35,000 people die every year here in the US for antimicrobial resistant infections. This is a major problem, obviously, for our patients, and it's not surprising that bacteria and fungi and viruses are resistant to things, because they have been fighting this battle against each other for superiority in the world ever since the world had began and these things showed up. And so most of our antibiotics come from these weapons that these microbes are using back and forth for each other, and we've been adapting them for use to give to patients in order to overcome these infections. Back about 15 or so years ago, there was a paper published from a group that studied antimicrobial resistance that went to look for flora that had been isolated from the world in New Mexico. So they went to Carlsbad Caverns National Park. They found this small cave that was in the back of the park that, because of the way the water table had risen and formed the caves and then lowered over the years, over the course of about 4 million years, whatever was in this cave, these bacterial flora, were isolated from the rest of the world, and in theory from any of the modern antibiotics that we have to use in patients. So they went into that cave and they sampled the bacteria there, and they took them to the lab. Then they tested them to see did they have resistance to the antibiotics that we have. And lo and behold, many of the bacteria had resistance genes to most of the naturally derived antibiotics that we have, and to many of the synthetically derived antibiotics that we have currently available. It's not surprising that these bacteria in our patients can become resistant, because they've got those tools already at hand to develop resistance as they're exposed to these antibiotics that we're using. It's right around the corner for a lot of our patients, and so one option is to use a bigger, better antibiotic. The problem there is that there are not a lot of antibiotics in the pipeline. So the other solution is to prevent resistance in the first place, and the best way to do that is using diagnostic and antimicrobial stewardship, because if we can prevent exposure in the first place, then we can prevent the pressure that's being placed on these bacteria to develop these resistance genes and express them and then share them with their friends. And so the first thing to do is to recognize which things need treatment and which don't. And when things do need treatment, then treat with the shortest course that's reasonable with the narrowest spectrum antibiotic that's reasonable. But recognize that a lot of things don't need diagnosis or treatment in the first place. So for example, if you have a child who shows up in clinic who's got a cough and a runny nose and a viral exanthem but also has a sore throat, well, that's probably a virus, and we really shouldn't be testing them for strep, because we know that about 20% of children in the wintertime will have strep colonization on their tonsils. And when we find the strep on their tonsils because we went looking, it's really hard to backtrack and say, hey, I don't need to treat this patient for strep, because every parent has heard that strep throat needs an antibiotic. So it's harder to explain away, well, this is a virus. Yes, the strep is there, but we don't think it's causing a problem. You don't need an antibiotic. There's other situations too, right? Not every ear infection needs an antibiotic. Not every pneumonia in children is going to be bacterial, especially our toddlers usually have viral infections when it comes to pneumonias, and so they don't necessarily need an antibiotic. We can use our clinical judgment there. We really need to do a better job of explaining this to our families. I know that you already are doing a great job of that. We just need to continue to reinforce that. Not everything needs an antibiotic. Antibiotics aren't benign. They can cause problems, and one of those problems can be antimicrobial resistance. So we also need to be doing a great job of reassuring our patients that we are here. If there is a bacterial infection that develops that needs to be treated, we're here to help with that as well. Looking at how we're practicing with our antimicrobial stewardship and diagnostic stewardship can really go a long way in preventing these infections in these children that can develop resistance. Well, that about does it for our ID talk this time around. Thank you again for listening. The Arizona AAP members can submit questions for future episodes to id@azaap.org. And Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services block grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thanks for all that you do, and we'll see you next time at the ID Talk podcast.